To address access and difficult access and access complications, we have none other than Dr. C J Varghese, who is the current AMASI president, and he is also the national executive member from Kerala of ASI. Over to you, sir.
Thank you, Dr. Alfie. Respected chairpersons, dear seniors, and dear friends. This is one of the basic topics to start with in the laparoscopy, that we all know that abdomen is considered as the magic box, and key to this magic box is laparoscopy, and it's so important that access to this magic box or the abdomen is very, very important. We should be making it without any significant complications. There are different types of access to the abdomen by laparoscopy. That is, one is closed and as well as open. And in the closed one, we have the Varghese needle method and a direct port approach and optical port approach. And the Varghese needle, that is, was introduced in 1932. We are all familiar with this needle, Varghese needle. It has got outer sheath and an inner one, cannula, and it's actually got a spring action. So as soon as it enters the abdomen, that the sharp outer the sheath gets retracted, so that it becomes safer for the viscera inside, and there won't be to avoid injuries to the vital structures. But still the complications can take place with this approach. It is not without complications. So while introducing this, there are some basic steps to be followed. First, we have to check the instrument whether that spring action is intact, it is working properly. Sometimes it will be stuck and you will land in trouble. And other thing that we need to select the site of insertion on the abdomen. Like usually the left upper, that the palmar point is selected, and it is considered to be the area with least problems. And other option is at the umbilicus or supraumbilical or infraumbilical or transumbilical, it can be placed. Or it can be placed even other areas, depending upon certain given situations, we may have to choose different areas. So there are a definite prescribed method of doing this technique, that you have to hold the Varghese needle like a dart or like a pen. You have to hold it, not like a stabbing method. And need to lift up the abdominal wall, so that the abdominal wall gets move away from the vital structures of the abdomen, the bowel and the blood vessels. And if possible, suppose we are doing in the umbilicus area, then it should be pointing towards the pelvis. The whole idea is to avoid that we are not directing towards the vessels, which should be avoided. And audible clicks will be heard as you pass through the facial layers of the abdomen. Usually 2 clicks are heard, and once you are experienced, you know that you are inside the abdomen. But there are different ways to check it, to make sure whether Varghese needle is inside or not. That is, first to aspirate with a syringe and make sure no blood or the intestinal content is coming. And then hanging drop method, that a saline is put on the hub of the needle, the Varghese needle, and the abdomen is lifted up. So because of the negative pressure, the saline sucked inside. So that also one way of making sure that you are inside the abdomen. Then we connect the insufflator with the low pressure. And the low pressure, when it is connected, there should be smooth flow of the carbon dioxide into the abdomen. Suddenly, the flow should be there. It shouldn't. Otherwise, if you are inside the facial layer, the flow may not take place, and that is one of the indications that you are not in the right space. And other thing is that the pressure on the, we may have set the pressure to 12 millimeters of mercury or 15 millimeters of 14 millimeters of mercury. So the pressure should not shoot up to that level all of a sudden. It should be on a lower level, that is about 2 to 3 or 5 millimeters of mercury. And in spite of a flow that is taking place. So then you are reasonably sure that you are inside the correct space. And once then the abdomen gets distended uniformly, and the obliteration of the liver dullness, etc., can be demonstrated. So these are the ways to make sure that that your needle is right in the abdomen. It is spending little time to make sure that it is all right, it is okay, it is worthwhile, because otherwise you will be insufflating into the wrong planes, or even sometimes landing with the serious complications. The closed technique is with a direct trocar incision. That is 10 trocar. The sharp tip is directly introduced into the abdomen. It is little scary, and it's mainly done by the gynecologist. We see a lot of gynecologists doing this method, and surgeons very seldom they attempt this, because we have dealt with the complications. So we know that once a complication take place due to this, it can be a serious event. So we try to go for other methods, either varus needle or open technique. So here there is a possibility of making a very major vascular injury or bowel or bladder injury. So that is a drawback. Otherwise, in expert hands, it's found out that this technique is also safe. The complication rates are also similar to the other methods. Then the open technique. The open technique is you make a small incision, then you make an entry into the abdomen. After that, the 10 trocar is introduced with a blunt tip. So it is considered to be safe, and a lot of surgeons, they prefer this method because they feel this is one of the safest way to the entry into the abdomen. So our choice is to go for open method in most of the situations, and when in certain situations only we go for the varus needle, and never we are going for a direct trocar approach. And it is considered to be safe, and it is without major complications, and the risk of extraperitoneal insufflation is almost nil, and the hernia chances are less because this facial layer is closed intact after the surgery. Disadvantage is said that it takes more time compared to that, but that's not completely true, because once you keep on doing it, your time taken also will be comparable to other methods. And it's not 100% against a major complications with this. When we have opened the bowel with the open technique, and we had to repair the bowel. And now if you compare these three techniques, that is varus needle and the closed 10 trocar direct puncture and open technique, if you look at the guidelines, the complication rates are almost similar in compared to that of the rates. What we are talking, complication rates are similar in expert hands. But the degree of complications is, when it happens, it will be much more in direct trocar approach. Because suppose you have hit a big vessel with a 10 trocar and you have punctured into that, the problems what you can come across, it will be much severe. So the recommendation is that what the surgeon is comfortable, you should be following, and there is no definite advice to follow either varus needle or direct approach or open method. The trocar incision, then it is comparatively easier because you already have the camera inside and you can place it under the vision. The only thing, the vessel should be avoided. There should be a guard with a finger on the trocar so that it doesn't go in too much and causing the injury to the bowel, etc. And then once you enter that, the sound also comes. And even with the 10 that the safety trocars are there, just like a varus needle. So as you enter, the blades gets retracted. That also considered to be safe. And now we coming to the complications of this access. It can be preperitoneal insufflation, omental or mesenteric emphysema, retroperitoneal emphysema, port side bleed, and injury to omentum, bowel, or mesentery, or the solid organ, even the great vessels. And here you see that the needle has gone in between the preperitoneal space and the varus needle, and the insufflation is done. The carbon dioxide has gone into this layer. It is not a very big issue. You can leave it alone. This gas get absorbed, and even sometimes what we see that after the surgery, the chest emphysema or the scrotal emphysema, all seen that, and all this gets absorbed. And even in cases where we do like fundoplication or surgery for achalasia, sometimes a pleural opening is made and then the gas gets into the chest. No need for a chest tube insertion, it gets absorbed. So the carbon dioxide, it's all get absorbed, so it's not a big deal. Now here you see that the bowel, that mesentery is insufflated with the gas. Again, you need to look into that you have to make out whether there is any injury or not to the bowel. So you have to rule out that. Sometimes anti-mesenteric, the border of the bowel would have injured. So sometimes you have to do some dissection and find out everything is okay. And if a bowel injury, definitely it has to be repaired. And the port side bleed is another problem. Like, see, there is an inferior epigastric vessel. The operator is trying to actually avoid that, ultimately puncturing that actually. You can see that, and then is puncturing that. So, definitely, if you take little time and see where the vessel is, definitely it can be avoided. But once it happens, it can be controlled by tamponade or by bipolar cauterization. Sometimes suturing is required, or the transfacial stitch is also helpful. Definitely it can be controlled. There's seldom any need to convert into open surgery. The injury to viscera, it is like, see, the multiple punctures that is made on the stomach. It's not a very big issue, this one. Sometimes it can be left alone, but definitely you need to check into that. Sometimes suturing is required. And here another injury to the bowel, that is seen that already that trocar punctured into the bowel, and this is a problem issue, your finger coming out and into the bowel. And here the issue that we need to, there are a lot of adhesions also. So we have to take a call whether this adhesion lysis need to be done before the bowel is repaired. Sometimes there may be more than one site injury in the bowel, and we all know a famous case that has taken place in Kerala. I think many of you sitting here will be knowing. It's got a lot of media attention, and then finally that patient died actually. The patient had more than one trocar injury, and only one of the trocar injury was repaired, the other one's left alone. And patient went to septicemia and died. And here hematoma, here you see that a big hematoma. Here again it's a tricky situation. You don't know what is underneath it. Sometimes it may be a very minor injury, you can leave it alone, but sometimes there will be a bigger injury. So we need to explore that if it is expanding, and then we need to make a repair. So usually we get a call from the gynecologist. Like I got a call from the gynecologist from a nursing home saying that hematoma like in the pelvis after the trocar has punctured into the vessel, and then we had to shift the patient to a bigger hospital. Then it was explored. Ultimately it turned out to be a common iliac vein injury, and that could be repaired laparoscopically itself. So difficult situations, previous surgery, dilated bowel loops, intestinal obstruction, ascites. Ascites, the fluid can come back into the insufflator. Then big tumors, large cyst, you have to make sure you are not directly puncture into that, and the previous mesh entry could be difficult. See here a big laparotomy. Suppose this patient has to undergo a laparotomy, then you can do actually you need not do the additional. Most likely additions will be in the midline, so you can, all entries can be from the left side, and you can still carry out the lap choles. You have to be careful. And here the patient with abdominoplasty, a mesh is placed, so your entry now to going through the mesh, you have to anticipate the mesh there, or initial entry can be in the upper abdomen where there may not be a mesh, and then subsequent entries may be through the mesh. So you need to plan. Here actually one of this appendicectomy, which when I was doing it long back, I don't know whether Dr. Alfie was remembering it, this patient was routine appendicectomy. The instrument was passed from the left iliac fossa port, and actually it has gone through the sigmoid. The sigmoid was dilated and distended. When the assistant or somebody passed the instrument, Maryland, it has gone through and through, and it came to the actually the camera was not focused on that. It is on the operative field. So the fecal matter on the tip of the Maryland, and then found what it is. Then we trace back and we see that actually it has come through the colon. So important lesson from is that when the port is away from your field, the entry and especially entry, not the exit, you should be actually under vision, because if you do it in a blindly, sometimes it may be going through the bowel and causing injury. And here another appendicectomy scar, the patient has to undergo TEP. Then still it can be done. It can be actually dissect around this adherent area of the peritoneum, and enough space can be created. And if even if make a hole or the defect in the peritoneum, it can be closed. So the message is that that even if previous abdomen scars are there, there are ways and means to carry on with the laparoscopic surgery, and most of the situations there is no need to convert into open surgery. And if you take enough care, this is one of the safest method. I think the entry into the abdomen is can be done without much problem. Thank you very much.
Thank you, sir. What would be your advice to a junior who is starting the laparoscopic career regarding the access? Which one to select?
No, I think that everybody should learn the both techniques, as varus needle as well as the direct, open technique. The open technique is it's easier to learn because it is our open surgery only. So, but the varus needle, yes, there is a learning curve in that. Definitely both should be learned, because we don't know. Like sometimes if you do open surgery, there may be situations we have to go for a varus needle method, because especially that entry may not be possible from the umbilical area. You have to make entry in a different side of the abdomen, and those situations varus needle entry is better.
See, the classical teaching is that for the appendicectomy, you will make a supraumbilical port and two ports in the iliac fossa. But some surgeons doing it in the hypogastrium. What is your suggestion?
No, that is again personal preference. This was my way of doing it. I think that there are people who make umbilical as well as suprapubic and right iliac fossa. I think that also perfectly acceptable. So I think it is the port positions can be variable according to the surgeon's preference. Whatever comfort, I think it should be followed.
So what technique you will use in geriatric surgery, open or a closed technique like that?
I always go for open method. Only situations where umbilical the area of the umbilicus cannot be accessed. Then, for example, a patient has got an umbilical hernia. So we need to do a IPOM. So the entry is from the epigastrium. So in those cases, we'll be going for a varus needle. So on certain situations only we go for the varus. Otherwise, it is by open method.
Sir, what about using VisiPort to avoid such injuries?
Yeah, actually I had a video, but I had not shown that. The VisiPort also is very good, and you can go layer by layer, and you know that when you are entering into the abdomen. Even E-tap also, now people are using VisiPort. That means E-tap, you have to enter between the rectus muscle and the posterior rectus sheath. So you can actually know that as you have gone beyond the rectus, and before puncturing the posterior rectus sheath, then you are turning it into the parallel to the muscle and getting into the plane between the rectus and the posterior rectus sheath. So the VisiPort is the only thing that 0-degree camera is very good. It should be used, not 30-degree camera. But we use most of the patients with a 30-degree camera. So we have to change. If you have to go for a VisiPort, start with the 0-degree, and then if you are going for a 30-degree, you will have to change into that.
Thank you, sir. A few quick points. One is for the juniors and the PGs. Make sure when you're putting the varus, the airflow opening is visible. Because when it goes in the other way around, when you're putting the varus, in spite of being in the peritoneal cavity, air won't be going. Then we have a confuse that are we in the correct place. So make sure that before putting the varus, you see that outflow, the vent flow or outflow of the air is seen visibly, and put it. Second thing is try to palpate the spleen, and also ask the anesthetist to decome to the stomach when you're putting the varus so that you're safe. And every time when you put in first port, diagnose laparoscopy, and all the ports to be visualized as you are entering it. These are the points to be kept. Thank you very much, sir. We will go for the next presenter.
Thank you.
As
May I invite-
answer to Alfie sir's question, for the juniors, one of the most dangerous weapon you can use is sharp metallic trocars. Nowadays, many centers are not using it, but many small setup people will give sharp metallic trocars, and if you are not used it previously, it may injure inside. So it should be very cautious in using sharp metallic trocars and avoid it anytime if it is possible to avoid.
Thank you, sir. We'll be moving on quickly to the next presenter, Dr. Sadashiva.